Hi, everybody. Welcome to the LACNETS meeting. It's March 9th. We're here streaming live from City of Hope in Duarte, California. I'm Lindsay. I'm the Director of Communications for LACNETS. I welcome all of you who joined us today in person, and I welcome everyone who's tuning in live on the live stream. We have a few announcements before we get started, and we introduce the doctors today. So, the June 8th annual conference is going to take place at Cedars-Sinai. It's our annual conference that we put on every year, and it's going to be a full-day conference. It's on a Saturday, June 8th, so mark your calendars. And the next LACNETS meeting is on April 9th at UCLA. It's on a Tuesday, and the topic is focused on PRRT with the UCLA NET team. And then we also have a meeting on May 11th. It's a Saturday. It's going to take place at Redondo Beach, the cancer support community there. And it's going to be from 10:30 a.m. to 1:30 p.m. with Dr. Eric Liu. And I hope you can join us. And now I'm going to pass it off to Lisa.
Hi, I'm Lisa Yen. I'm LACNETS Program Director, and I just want to welcome all of you also, and thank City of Hope, Drs. Singh and Dr. Lee for hosting us today. It's really exciting to be here, and it's always a great place to meet. I just wanted to encourage all of you, if you are not already signed up for our general email list, this is where you get all the announcements about all the meetings, all the latest updates in NET and in what's going on in the field. Also, for those of you who are interested, we have a private internal LACNETS email group where you could post questions, discussion questions, and hear from other patients about their treatments or opinions and things you want to discuss with other patients internally. And to sign up for that, I would just email Lindsay at events@lacnets.org or just email us through our webpage. Also, we have a peer buddy mentorship program called NET Connect. So that's a way for you to be paired up with another patient or so. If you want to talk to someone else about a certain kind of treatment, a certain type of disease, someone who's further along in the disease than you, that would be a way to go. And you can email me at lisa@lacnets.org. Another thing that we've developed along with Dr. Dan Lee here at City of Hope is the Net Vitals, which is on our website, and it looks like this. Is a patient-physician communication tool. So many of us, as you are aware, see many doctors for our appointments, and that might involve getting multiple opinions, and we might have information at different places, and lots of different terms, lots of different scans, lots of things to keep track of. This is a way for us to prepare for our appointments by going through and filling this out. You can learn more about your own disease and then come prepared to your doctor's appointments. And that's available on our website, and we also have copies there in the back. We have a webinar that we did along with Dr. Dan Lee, Giovanna, and myself, who developed the Net Vitals, along with Josh Mailman from the NorCal group, that helps walk you through the Net Vitals communication tool so that you can figure out how to do it. You're not doing it by yourself, and understand some of the terms, and again, be better prepared for your appointment. Also, lastly, but not least, I want to introduce Dr. Dan Lee. And Dr. Lee is the medical oncologist and co-director of the Neuroendocrine tumor program here at City of Hope. He's really well known to us. He's very active professionally in the medical oncology and NET medical associations. In fact, ASCO, the American Society of Clinical Oncology, last year awarded Dr. Dan Lee as one of the rising top 40 under 40. And this was the first group that they awarded and recognized early career leaders in oncology that are celebrated for their contributions they're making to improve the lives of those affected by cancer. He's really active in research. He's really passionate and dedicated to look for ways to help NET patients. And he encouraged Giovanna and I to dream big. And that's part of why we're here today. He co-developed Net Vitals along with us, and he's a really huge supporter of the NET communication community as a whole, as well as LACNETS and individual patients. So we're really appreciative for his support, and thank you, and welcome, Dr. Lee.
All right. I just want to welcome everyone for coming to the City of Hope again. I think it's been about 3 months since we had you last time. Thank you for LACNETS for organizing this and really helping the entire NET community going forward. So I'm going to be introducing today's speaker. So today's speaker is Dr. Gagandeep Singh. He's kind of my counterpart in surgery, so he also co-directs the Neuroendocrine tumor program here at City of Hope. Dr. Singh is the chief of surgery here at City of Hope. And I want to say I could not have built this program without him on a personal level. I remember arriving to Los Angeles about 3 years ago, and we had a good program, but our program was relatively small. And we really had to think about, how were we going to do this together? And I know that as a medical oncologist, while I oftentimes are focused on systemic treatments for my patients with neuroendocrine tumors, I really realized that surgery is an absolute crucial part in the care of NET patients. If you talk to most of the NET surgeons across the nation, they feel that probably surgery is the most important part. While we can have debate about that, I do recognize that surgery is absolutely imperative in the care of neuroendocrine tumors. So I thought that it was really important today to pick a topic specifically on surgery. Oftentimes we talk about surgical resection of primary lesions, but oftentimes for patients with neuroendocrine tumors, you will have sites of metastatic disease. And it is really, how does surgery come to play in the role of, for patients, particularly patients with liver metastasis, how are they going to ultimately live with this disease long term? So without further ado, Dr. Singh is going to be really defining order beneath the chaos, living with neuroendocrine tumor liver metastasis. So Dr. Singh, please.
All right, welcome everybody. Thank you for coming on a Saturday. Really do appreciate that. Thank you, LACNETS, and welcome to City of Hope. I have a lot of information. I'm trying to simplify it so that it doesn't get too complicated. I've been interested in neuroendocrine tumors for about 15 years now, and it all changed when I operated on somebody who was 18 years old and needed a total pancreatectomy for neuroendocrine tumor extending through the entire pancreas. And then she also had liver metastases at that time of presentation. And I've been faculty surgeon now for almost 20 years. And that was a tipping point because it didn't make sense to me why an 18 or a 19-year-old should be developing a cancer at such a young age without any genetic predispositions. And so a lot of the stuff that you're going to see is science and evolution, what we've changed over the last 15 years. And we've actually supported a lot of this by publications. And 3-4 years ago, when Dan came from Memorial Sloan Kettering straight out of fellowship, it was perfect because I needed somebody as a good partner on the medical side of therapies to complement the surgery. And he's totally helped us bring the program now to national recognition. In fact, we have a trial opening that's only opening at 3 centers in the country and two or three centers in Europe. And again, still in preliminary processes, very exciting field, and hope to build more optimism as I go through the talk. Now, there's a lot of pictures in here, and a lot of it is patient pictures, so I'll try to go through those a little bit quick. I don't want to make it gory, but I want you to understand that not everybody has the same burden of disease, and we tend to generalize and say, A has got liver metastases and B has got liver metastases, and they should do exactly the same way clinically. So with that, I'm going to go ahead with the talk, and as you can see from here, neuroendocrine cancers has been progressively increasing in incidence. And in fact, when we looked at it, it's a 7-fold increase in the last 40 years. I specifically also looked at California, and even within California, there's been an increase in the neuroendocrine disease in all areas. And there are a few pockets that we've been able to identify that do have a higher incidence. And I cannot explain it. We just acquired the pollution data for the food, water, and soil, water, and air. But it's extremely difficult to try to figure out if there's something going on in these regions specifically, because the way it's coded for districts and the zip codes is not the way clinical medicine is coded. So our statistician's been trying for about a year to try to see if we can find anything that may be of significance here. As you know, neuroendocrine tumors can arise almost anywhere within the neck, down into the chest and the lungs and the mediastinum, where there's a gland called the thymus. In the abdomen, there's solid organs, adrenals and pancreas. The pancreas is tucked way behind the liver and the stomach here. And then from all the tubular structures within the body, as you can see, the stomach, the large intestines, the small intestines, again, the large intestines here, and then down to the rectum. And biologically, a lot of these behave differently. The problem with neuroendocrine tumors is that they're so small, and when you see pictures, you'll understand why it is difficult. For the most, people have vague symptoms and really don't have anything to really talk about in terms of symptomatology. And so by the time they present, a lot of the patients already have metastatic disease. Now, when I started doing this about 15 years ago in a big way, people would say, oh, there's metastatic disease. These patients are going to live 10, 15 years. Let's not do anything about it. And that was true for some, but there were others that were progressing very rapidly. And so it is important to differentiate that. And now, after we've added surgery, what we're hoping is, I mean, this is a 1989 slide preparation. What we're hoping, and at that time, they used to feel that it would take 20 years for the lifespan of this particular patient. But what we're hoping now is to be able to increase that to about 30 to 40 years. In other words, try to give you normal expectancy. And so that's why I said living with liver metastases or living with neuroendocrine disease and just accepting it to a certain extent. If and when we find a cure along the way, which believe it or not, we're working every day at it, we do hope. And I was just talking to one of the patients that I've operated on about 6, 7 years ago, saying that, you know, we keep trying and we've got new molecules that are coming out that are in 2nd and 3rd generation, and we're trying to work towards finding a cure for these. Now, as you know, that most patients will, once it goes to the liver, not most patients, so I'm going to take that back. Some of the patients, then the disease goes to the liver, will have symptoms, and it's flushing. And the classic thing about flushing is that there's no sweating. So it's not like perimenopausal changes where you start having hormone fluctuations and you have a lot of night sweats. The classic thing about this flushing is that you're really not sweating. The other thing is patients do end up having diarrhea, and the diarrhea is usually nocturnal. So in other words, they end up getting up in the middle of the night to go for a bowel movement. So there are a couple of things here which are distinguish it from the routine irritable bowel syndrome and that need to be kept in mind. Now, of the pancreatic neuroendocrine tumors here, again, the pancreas is tucked behind the liver and the stomach here, about 30% of these will spread to the liver. And of these 30%, 60% of the patients are going to be non-functional. So in other words, no symptoms whatsoever. And about 40% will have some amount of functionality with them. Again, some flushing, some degrees of diarrhea, et cetera, that go with it. Whereas intestinal tumors, and now I think the term carcinoids is going to go away as time goes on. Carcinoids was cancer-like. These were slow-growing tumors, and that's why they were likened to cancers. We know today that these are truly cancers, so they are neuroendocrine tumors. And so the term carcinoid, which is loosely used for anything arising from a luminal organ, in other words, intestines or the stomach or the large intestines here, is called carcinoid tumors. Of these, 70% of these are going to end up going to the liver, but only 10% of these patients are really going to have symptoms from the metastases to the liver. So surgery is the gold standard when possible. And so that's the first question I always ask myself at this point. It may change in 5 years, it may change in 10 years, maybe not 5 years, but in 10 years, if we have more effective therapies, we probably will go away from surgery. But at this point, we don't have. So surgery plus a combination of Dr. Lee's magic it makes a lot of difference for our patients in the long term. So what do we do in surgery? The most important thing is to identify where your primary cancer is, whether it's in the pancreas or it's a carcinoid, i.e. in the intestines. I'm not getting into the chest, but there are lung carcinoids also. There are thymic carcinoids. They're all biologically different. I'm going to keep my focus at this point predominantly to abdominal carcinoids or abdominal neuroendocrine tumors. It is important to find them, resect that, and then take out all the nodal disease with it. Resect the liver metastases when possible. If it's not possible, yes, you will do a conservative management. And if you think the patient is going to need somatostatin therapies and you're in the operating room, the gold standard is to try to take the gallbladder out, because somatostatin affects the emptying of the gallbladder, so patients develop stones, pain, right upper quadrant discomfort associated with it. And of course, the last thing I teach our fellows and residents is that they should always be prepared for carcinoid syndrome in the operating room. So it doesn't matter what the magnitude of the operation is. For example, that young girl that I talked to is now married, is over 30 years old, and doing fantastic. But I definitely feel that if I hadn't taken out the primary cancer and I hadn't taken out the liver metastasis at that time, that she wouldn't be 12 years out today without recurrent liver metastatic disease at this point. So there is something to be said about removing the primary cancer here. So it could be just the head of the pancreas, which is called a Whipple, central, distal pancreatectomy, or even a total pancreatectomy, depending on the magnitude of the disease. And if we need to reconstruct the blood vessels around the pancreas, then I don't hesitate to do that as long as I can achieve what I call an R0 resection or a naked eye clearance. Now, small bowel neuroendocrine tumors, which is actually the bulk of the patients, and a lot of people will have these on the small intestines, these are very, very subtle. You cannot actually even see these on a scan. As you can see, they're almost like a hairline. And then these migrate to the nodal nodes within the region of the primary cancer. So the gold standard again remains is taking out the segment with a decent margin on either sides and also taking out the nodal disease. And once you take out the main cluster of nodes, I usually sample lymph nodes on either side to make sure there's nothing beyond at least what I'm seeing at this point. And again, to impress upon you, that's the size of the primary cancer. That's the burden of the liver disease. Now, if you don't take this out, it's going to continuously keep showering disease within the liver. So the logic to this is that you do need to take the primary out, and it prolongs the lifespan of this particular patient. So this is our study that was published in the Annals of Surgery, which is our highest impact factor journal in the surgical arena, and was published last year. And basically, it shows you that when you take out the primary for a pancreas, mind you, this is with or without liver metastases, and I'll add one more step to this after this. There's a definite advantage of taking out the primary. You can see the survival is much better in this patient population. Same for colorectal. There's an advantage of taking out the primary, and then there is an advantage of taking out the primary even for the small intestines. The only one that we did not see a statistical advantage was for the stomach carcinoids. And I think that was primarily because there were just not enough cases in the California Cancer Registry or at City of Hope that we could actually look at the statistics through that. Now, this is the next step. If you take out the primary and you treat the liver, this patient does much better than the patient that you did nothing for. You left the primary and the liver disease behind. Now, if you just treated the liver and did not take out the primary, they do worse than those that you took out the primary. So again, the point being here, The primary cancer, whether it's arising from the small intestine, or it's arising from the pancreas, or it's arising from the colon cancer, I think definitely needs to come out because it is continuously showering metastatic disease beyond that. And we want to prevent it from getting any further than it actually is at that point. So how do we approach this from a liver point? And now this gets a little bit complex, and I've tried to simplify this, and I'm going to go through some of the therapies, and I'm sure that'll open a whole can of worms. I'm happy to discuss the pros and cons of some of this. But what we rely on essentially is the regenerative potential of the liver. That's number one. And number two is how much liver are we going to leave behind, what we called the future liver remnant. We've known about the regenerative potential of the liver from Greek mythology. As you can see, this is the god of fire, Zeus. This is Prometheus, who stole fire from the god of Zeus, the god of fire, and gave it to the common people. But in turn, he captured him and put him against the Caucasus Mountains and would send his eagle to perch on him and eat his liver every day. So we know from that time onwards the liver regenerated, and there was enough for this liver to regenerate because this eagle would have enough to go in and get a portion of the liver. What's important is in liver surgery that no matter which way you go, it's a cluster of blood vessels. So it's not that straightforward as one thinks it is, because you can cut this way or you can cut this way. You are going to encounter a complex inflow and outflow of blood vessels that are associated with the liver itself. And then to add one layer of complexity, I think we missed. All right. To add one layer of complexity, if you look at the liver here, you can see, again, this is inflow and outflow. And if you're trying to remove tumors within this whole portion, it is fairly complex procedure trying to do that. I give a lot of credit to one person back in 1954, that is Claude. He was an anatomy professor who was actually brought back from his anatomy teachings into the surgical world by one of his students, who actually then worked and came out with the segments within the liver and deciphering the exact inflow and the outflow tracts within it, which actually made our understanding a little bit better. And having said that, even with that, it's not that straightforward. I mean, we have to work our way between all these blood vessels as they're going through. And more importantly, the blood that's coming in from the intestines here into the liver is going through these main channels into the main blood vessel that drains right into the heart right here. So we're dealing with a lot of these things within close proximity, within a couple millimeters of each other, trying to do a lot of major work here. And you will see as I go on through this talk, the complexity of liver metastases, which I've again tried to simplify for your understanding. A lot of people do get CT scans for liver metastases, and this is the scan of the same patient, and you will see that I have moved away from doing CT scans to doing MRIs now. And the reason being that the clarity that the MRIs now bring to us is far more than what the CT scans bring to us in terms of being able to identify metastatic disease or even a subtle spot within the liver. And again, this is a changing paradigm in the last 3 years, and I think it's beginning to influence the way I think of liver metastases also, because obviously up until 3 to 5 years ago, I relied entirely on CT scans to identify the burden of disease. I think both of them go hand in hand and complement each other to a certain extent, because I think the CT scans do provide good anatomical information in terms of the blood vessels. The MRIs at that time were getting better, I think are almost equivalent now in being able to get these, but it's very technician dependent because there are a lot of breath holds involved. They're 10-second breath holds, and if you breathe through those, the images are completely fuzzy. So the MRIs, unless they're done well, and they're done at some of the centers where we've worked, day and night to standardize these protocols so that we can capture these images to the detail that we're looking at. I don't recommend an MRI routinely at an outside facility because I know they're not going to be able to deliver the results that I'm looking for. The octreotide scan, which used to be a big thing from the past, we've almost stopped doing them now. And we've moved to what's now called the gallium-68 scanning, which is similar to the octreotide scanning. It's tracer marks, so you can actually see these light up like mini light bulbs within the liver, the mesentery. You can identify and find your primary. Again, you can't see the primary cancer in the small intestine here, but you can see the node, the lymph nodal mass. So this now points you to saying, okay, there's got to be a primary in the small intestine in this particular patient. Here's another example where you have a little lymph node that's lighting up at the base of the liver, but of course we don't see the primary, and then we know that it's probably coming from the stomach, so you do an endoscopy and you can find the primary from where this neuroendocrine is originating. And the same goes for the neck, where you can now identify disease within the neck also of neuroendocrine origin. But you have to remember, these scans are sensitive predominantly for tumors that are 1 centimeter and above. As you go below 1 centimeter in size, the sensitivity of these scans keeps dropping. And I think below 5 millimeters, it's very difficult to be able to pick up this activity or this little burst within the tissues of the tracer that you're looking at. So in the operating room, I still recommend doing an intraoperative ultrasound. So if I'm doing liver surgery, I always do another intraoperative ultrasound to see if there's more disease than I could actually see at the time of the scan, and see if I can actually clear that at the same sitting. Now, there are several modalities, and it's not going to be possible for me to go into the most, but I'm sure when you Google or get on the internet, you're going to see a lot of this. So I'm going to touch a little bit on it and then sort of give you my own preferences and the way I look at this. So surgery, of course, for liver metastases when it can be done. And again, I'm going to simplify that equation for you in a second. Somatostatin analogs, immunotherapy, targeted immunotherapy, chemotherapy is Dr. Dan Lee's forte. I work extremely closely with him on this, and we discuss our patients at a multidisciplinary tumor board, which is only a neuroendocrine tumor board. We also discuss when we need to transition from here to using PRRT or lutetium-177 or yttrium-90, depending on each patient's rate of progression of disease and where we think what we can offer to control it. Now, you can't throw everything at one time at the patient because it's a body at the end of the day. So you have to balance it out. I have started seeing patients that have actually gone to Europe, gotten treated, and then come back here because we did not have lutetium, now showing up with long-term side effects of lutetium therapy, 7 or 8 years out. And there is nobody treating them on the outside, so they end up with coming to us looking for help, and we're happy to take care of them. But what I'm saying is each one of these therapies has some amount of toxicity and some long-term side effects associated with it. So let's not just rush into it because you see it on the internet and everybody's saying, let's go get lutetium, let's go get yttrium-90, let's go get this. Don't rush into it. Just take a deep breath. You're going to live through this, and we're going to work with you at every step of the way. And that's the most important thing here. There's microwave ablation. There's irreversible electroporation, and I'll explain that to you in a second, which is nanoknife. We're one of the few centers, and probably I do have the largest experience using this selectively. Chemoembolization, bland embolization, radiation embolization, or radioembolization. And I'll show you pictures of these in a second just to explain a lot of these things to you. Cryotherapy, ethanol, transplant, limited donor pool, and gene therapy, I'm going to take out of the equation, but I will probably spend a minute or two trying to get through some of these things in a little bit of detail. PRRT also, I'm going to skip. Basically what this is your octreotide molecule attached with a radiation molecule, which allows to track, takes the octreotide to the tumor, and the radiation kills the tumor basically. And again, there's limited use. You don't want to use this right up front because at the end of the day, it is radiation. You cannot keep blasting the body with repeated doses of radiation. So again, This needs to be thought out in a systematic fashion. And again, this is one thing that we take great pride in, actually thinking how we need to go from one treatment to the next treatment, and based on the rate of progression. So cryotherapy is basically putting a needle probe inside the tumor and freezing it into a big ice ball. At that temperature of -30, all the tissues, the tumor cells completely die away. However, the issue is there is a 65% recurrence rate associated with it, so I'm not a big fan of this. It was great in the 90s. It made a little resurfacing in about a couple of years ago. It's great for kidney tumors, but not great for liver tumors. Microwave ablation and radiofrequency ablation. Radiofrequency was the energy that we used 10, 12 years ago. The next energy form now we're using is microwave ablation. It's a lot quicker than the radiofrequency ablation was, but the principle is essentially the same. You put a needle or a starburst within the tumor and basically it burns it. Whether that is generated by heat or whether that is generated by rotation of the water molecules, the principle behind it is the thermal coagulation of the tumor within the tumor itself. There is a 30 to 40% recurrence rate within the tumor, and especially if the tumor is greater than 3 centimeters in size. So it's not one size fits all. You can't just indiscriminately put it in and create 10 holes within the liver, because these are ultimately going to become abscesses. So again, there's a good amount of balance that has to be directed within this therapy. The next modality is the nanoknife, and I actually like this a lot. This is the most, I would say, the newest energy form, and what this really is if there are tumors surrounding some of the critical blood vessels, it's impossible for us to take out that critical blood vessel. Let's say it's the inflow coming into the liver, or it's the outflow going up to the heart, and it's not possible for us to resect that with a good degree of safety. Then you can essentially put a needle on one side, a needle on the other side, and give electricity across this. So you give the same thing that we use its actual electricity. You give 90 volts, you give about 3,000 volts, sorry, 90 pulses, enough to actually destroy a 2-centimeter tumor in a critical location. So I use this for margin enhancement. I use this for tumors that are located around very critical structures as within the liver itself. And that's what the needles look like. And that's the generator that we use. The next new generator is now, it's been 8, 9 years. They haven't come out with something which is a little bit quicker. So it is a little bit time consuming still to do this. It does take us, especially if the tumor is greater than 2 centimeters in size. Now, embolization. What is embolization? And people talk a lot about this too. So it's basically accessing the liver artery that feeds the tumors within the liver. And you can actually block off the blood flow into these tumors by just putting bland particles. You don't really need to put any chemotherapy directly into it. You can just put particles and it will knock out the blood supply within this. It has to be done in a balance. It's not done for like 20 tumors because you can't identify specifically these tiny branches in 20 different tumors. So you do it for the tumors that are not responding to therapy or that are isolated, that are growing despite all our other therapies, that we do bland embolization. If instead of using bland particles to block off the blood supply, you use yttrium-90, it's called radioembolization, which is a radiation molecule now being directed into the liver for the treatment of these tumors. And if instead of using yttrium on these particles, you add chemotherapy or certain chemotherapy particles onto that, it's called chemoembolization. But the principle of all of these remain the same. You identify these tumors and you can actually treat these tumors with different modalities. Again, each one of these is thought out as to why and when we use radioembolization versus chemoembolization and what the burden of the liver disease is at that time. In terms of liver resection itself, how do we design them? If it's a big single lesion, you just go after it and you resect it. If it's much bigger than that, obviously we don't have enough residual liver left behind. So we need to reduce the size of this tumor. And we have several different options. And then that's where I work with Dr. Lee very closely either using systemic chemotherapy, using the selective internal radiation like Y90, the embolization we talked about, chemoembolization, and what we call portal vein embolization, which is actually a different technique, and I'll tell you about that in a second. You get size reduction, and you go after the tumor. What do we do if we have multiple tumors? We can safely remove these tumors if we know that the remnant that we're going to leave behind is greater than 30 to 40%. However, if we are going to be cutting short on these, then we have to come up with an alternative strategy, which is called portal vein embolization. This is done by our radiologists, and I will show you a picture of John Kessler, who does a lot of our work. And what he does is basically comes into the liver through a vein and blocks off the main flow that's going on to the right side, because that's where the bulky disease burden is. I know that I'm going to be short on liver here if I take this out too, so I need enough liver left behind so that I can have the patient recover healthily after the surgery. And so this 1.5 liter per minute of blood flow that is going through the entire liver is blocked off at this level and now redirected to the left side, which leads to a compensatory hypertrophy or increase in size by about 8 to 13%, now giving me a little bit more luxury of room to work on this liver if I don't have enough volume that's going to be left behind. And now I can go after that liver resection a lot more safely and work at achieving what I say complete naked eye clearance in this patient population. The last strategy is just to take out the small portion, leave the big portion in, continue with therapy, wait for that liver to grow. As I mentioned to you, liver is one organ that regenerates and grows back to 100% in volume in approximately 3 months, and then come back and get the remaining portion of the liver disease at a second stage, provided we have ability to control it. This is a new concept. There's only one case report of this for neuroendocrine disease, but it is beginning to come up for other cancers. And so it's a little bit out there. I'll just mention it for the sake of knowing it, but I don't think you need to think about this too much. And this is called ALPS, basically. What they've done is, in order to, they don't want to take out, because they're taking out a little bit more than 70 to 75% of the liver, leave people behind with too little liver behind. And so what they do is they completely divide the liver, but leave some amount of blood flow going into the right side, so it's still alive. Give 9 days for this portion to actually regenerate in volume, and then go in and take the remaining portion of the liver out here. Not recommended at this point. I definitely think it's out there, and people are just kind of pushing the limit, but I think we're missing what's the biology of the disease. Can we do liver surgery laparoscopically? Yes, I was probably one of the first to do this back in 2005. But again, for neuroendocrine disease, one has to remember tiny incisions is not always the answer to good operation. So you have to base it off. And also the second thing, as you will see in the subsequent slides that are going to come up, is that the disease within the liver is not a single spot. If it was a single spot and was easy to get, I think laparoscopic surgery would be great in that situation. But you can get out a major lobe, which has 5 tumors within it. And there's somebody who had a primary in the colon first. He had that resected, then came to see me for a liver, which had 5 tumors within it. Today, this is about 10, 12 years ago. Today, I wouldn't do this because I feel I had to take out so much of normal liver for this patient, which I could have potentially saved. So I would have focused my attention on some of the bigger ones and then put a needle in and ablated the smaller ones, so that I'm still leaving the patient behind with good amount of liver, because I want to push this to 20 to 30 to 40 years of survival for that same patient. So yes, we can do laparoscopic surgery. Is it always the best thing to do? And that is the thing that you have to leave to the judgment of the surgeon when you come to see him. I think you've got limited disease, you've got a single lesion, it's perhaps something that you can consider. Laparoscopic surgery is extremely difficult when the rib cage, because these are rigid instruments and you're fighting the rib cage here. So doing tumors that are located directly under the rib cage over here are extremely difficult to approach with a laparoscopic approach. However, with the robotic approach today, we can actually have these arms reticulate in the 7 directions of what your hand does. So it replicates your hand movements on the inside. So we can still get a few more then we could get laparoscopically. But the problem and the limitations of the robotic technologies, I think it's getting better every day for liver work. It's great for the prostate. It's great for some of the intestinal work, but it's not great at this point completely for liver. We are pushing the pendulum. We are trying to do them. And it has made surgery for things that are under the rib cage a lot easier. But at this time, it's still not mainstream. So I always say you want a good operation rather than just having tiny holes, because you don't want to be back there dealing with complications or an incomplete operation because it's done laparoscopically. Now, do I think robotics is the future? I do think robotics is the future. We are one of the biggest centers for robotics in the world, actually, and we've done about 13,000 cases here at City of Hope, and a lot of those are actually prostate cancer, almost 10 to 12,000. So almost everybody who's trained for robotic prostate surgery at some point was trained at City of Hope. And we've used the expertise of our urologists to actually push the envelope of robotic surgery for GI surgery, or in other words, gastrointestinal, for the stomach, for the liver, the pancreas, et cetera, et cetera. And I think we're getting better, but we're not perfect, and we're not there yet to say everything should be done robotically at this point, and it should be done through these tiny holes. Because remember, a solid organ like the size of a liver, you still need to make an incision to pull it out. You can't take it out to a little tiny hole. So there is a balance that needs to be drawn when you're doing this. So the question is, are we there today? I don't think so completely, although we are not going to stop trying. We are going to try to see so that the next generation of surgeons and the next generation of patients can definitely benefit from this technology. The most important question, and this is the critical part for people who've got liver metastases, I would urge you to look at these slides that are going to come up. And these are patient pictures just to give you an idea of what the burden of liver disease can look like, and what livers we should go after and what livers we should not. And you'll be surprised. Everybody tends to think of liver disease within liver metastases from neuroendocrine tumor as one thing altogether. So the most important question is, what is the burden of liver disease? And in order to simplify this, I proposed a classification which has not been fully accepted. And I was at the pancreas pancreas neuroendocrine tumor consensus conference last year, where about 15 to 18 surgeons met to come up with some of the guidelines for pancreatic neuroendocrine tumors. And I was tasked with trying to figure out how we should simplify, or how we should establish safety for liver surgery. And I recommended a classification, which I'm going to share with you. It's not accepted yet, so it's something that I thought was simple enough that people could use. So type 1 would be a large single mass, and I'm going to show you examples of all of these in a second. Type 2 would be maybe a single mass or on both sides of the liver, but essentially resectable. In other words, I can cut those out with surgery. Type 3 is there's just way too much disease. So I need to back off, not do something that's not right. I need to send the patient to Dan, try to maximize therapy. There are patients that I have been able to take out 80 or 90 tumors in these cases, but most of them are superficially laden and controlled. But in my mind, when I'm going into those patients, I know that I'm going to achieve at least somewhere between 70 and 90% of visual cancer control there. And that's when I'm giving them a benefit. If I'm going to leave more than 50% of that disease behind, then there's no point in chasing that. I'm not going to do justice to that particular patient. And the last is completely for palliative reasons. There are patients with huge tumors with complete discomfort within their abdomen and are miserable. And so you do a debulking surgery basically to provide them with palliation. And I'll see a lot of these patients every year where they're impinging on the main blood vessels and I'm going to strangulate the flow within them. And in order to give them life, all I need to do is just take out that one dominant tumor. And if I can take it out safely, then I will offer them a palliative resection, not with the intent of cure, just go in, focus at that one area, come out, give them symptom relief, and then have Dan look after those patients. So let's see an example of each one of these. So this is type 1. You can see a large tumor within the liver and a large tumor, actually, which was in the pancreas. And again, I know that this is a difficult resection. Actually, the pancreas is harder than the liver. The liver is pretty straightforward because it's a single resection. I should be able to get this. The harder part is going to be whether I can get this off from the pancreas with the intestine, with all the blood vessels, encased within this. She was young, she was 22, incidentally palpated this when she was working out in the gym. And we did actually end up resecting this tumor. As you can see, I took it out with a segment of intestine with the pancreas, and then I reconstructed, and then you can see that I did actually go ahead and do a liver section at the same time. Type 2, where you have multiple but still removable. Now, I've not put a definite number on this because it's not possible to say I should stop at 12 tumors or whether I should stop at 25 tumors or whether I should stop at 40 tumors. I think it's a visual judgment call, A, based on the scan, and B, based on what you actually end up seeing in the operating room, because they're completely different sometimes. And you have to realize that scans are not going to pick up the sub-centimeter lesions, which you're going to see in a second on some of these images now. So this is type 2. This is a pancreas mass, neuroendocrine tumor, with subtle liver metastases. I know that this I can control. So I'm going to offer this patient a resection or a Whipple for this particular operation, and then try to get these liver metastases out. But again, look here at the smaller burden of disease that you see. The question is, I can see these so I can get them. And I do an intraoperative ultrasound, and if I see anything in the depth and I can get it, I will get it. But if I don't see it, does that mean there's no disease in there? And that we don't know the answer. But the question is, I am resetting the clock to microscopic disease and hopefully adding another 10 years to the 20 years we talked about earlier. And again, I don't have data to say that today, but perhaps in 10 years, if you're here and I'm here, and we'll probably might have the data to be able to tell you about that. Here's a small bowel neuroendocrine tumor. And again, I want you to look at the burden of disease within the liver itself. These are tiny holes of clearing all of these tumors out. This side yet has to be done. And you're working through it, and then I'll work at the undersurface, and then I'll go after the stuff on the inside, and you work after this meticulously. But again, there is no way a scan is going to be able to pick up this or this, and that's why you'll find scans a little bit erratic when they explain the burden of liver disease, whether it's an MRI or a CT scan. I think the MRI may still pick up a half-centimeter lesion like this, but a 2 or a 3 millimeter lesion like this, the MRI is not going to be able to locate these metastases. Type 3. Now, these could be, again, way too much disease within the liver, and I wouldn't touch these. And I would call Dr. Lee and say, Dan, this is something that you need to control, and we can revisit surgery at a later time if you have better control on it. So again, you can see this, the burden of disease. There is no way for me to carve everything out and leave behind just this portion of the liver because of the way the blood supply is going through this. She does have a pancreas primary. So I did go in and take out the pancreas primary. She just passed away last year. But what I'm trying to say again is we did give her 7 years by slowing down the progression of the disease. And here's where I'm going to make a little thing. She went abroad. She actually got yttrium 90 with us. So we actually had very good control. But her tumor markers were still hovering a little bit on the higher side. She had the ability and the means to go abroad, got PRRT abroad, and came back. And 6 months later, she went into profound liver failure. So again, what I'm trying to say to you is, let's not rush into this. Let's just take a deep breath and move along. Only when we see progression. We have to balance out therapy within the liver itself, not just throw everything at it just because PRRT is available. Now, I asked these same questions to our colleagues from Europe, and they said they don't see these problems because their patients come back here, and when they go back there, they don't see these. They actually never make it back to them 10 years later or 5 years later with these problems that are occurring later on. So again, balance it out. I'm not saying it's wrong. Maybe we're learning along the way. So I think the intentions were all good. For the patient wanted it, and I couldn't make her think otherwise and say, don't go for it right now. It's not the right time. You have good function. But guess what? Yttrium-90 was radiation beads, lutetium-177 radiation beads. All of this blasted into the liver, 4 rounds of lutetium, couple of rounds of yttrium-90, the liver is going to take a beating. There is going to be long-term scarring with that. So let's balance it out. Let's maximize our therapies and push these things away and use them only when we really need to use them. Now, we're trying to develop better algorithms with definitive time points for this. We don't do it individually. We do it at the tumor board, where we discuss these patients and say, okay, I think it's time to consider this. Or Dan will say, Gogs, this is working much better, and let's do this instead. And so we move, and we're open, and we work as a team on this to make this happen. But if you look here carefully, she had an amazing response to yttrium-90. I would not have done lutetium at this point. And she was doing extremely well. But it is what it is. We learned from this tremendously. Here's another liver, just to give you a visual idea. This is not in our liver with liver metastases that I can resect or take out. So again, you have to draw a finite line. Not all livers are created equal in terms of burden of disease here. This is another primary. You can see that the primary is so subtle you can barely see it. When you magnify, this is the magnification on that. There is a large nodal mass. And look at the liver disease here. This is the burden of liver disease. There are tiny spots everywhere. There is no way I know that I can clear this patient out. So again, I am not going to rush in and try to clear this patient out, because I know if there are microscopic and tiny spots here, there are probably hundreds on the inside too. This is once again a patient that I would come back, I'll talk to Dan and say, let's give this patient systemic therapy, control this by 10 years, and then we'll see if we need to go to lutetium or something else. Here, I know that I'm not going to be able to achieve a visual clearance of more than 70%. So it's not, again, I have to balance it out in the operating room and then make a team decision afterwards. This is type 4. This is a young man, actually, he was 53. Large mass, biopsy proven on the outside. They told him nothing needs to be done, nothing needs to be done. It's a neuroendocrine tumor, it's a slow-growing tumor. You'll get 10 years out of it. And again, he came to us with primarily just discomfort. He said, I feel like I'm walking with about 30 or 40 pounds of weight on me. So, of course, the scan showed a big mass. We took him to the operating room, and you'll see that's the size of the tumor we took out. And this is still his liver that's left behind, which is riddled with tumor. And this was done exclusively for palliation, not with the intent that I could control this disease. He went on to systemic therapy afterwards for the burden of liver disease. So again, this is completely a different setting in terms of what we can do based on the burden of disease here. So once again, just quickly recapping, type 1, type 2, type 3. I recommend resection. If it's less than 3 centimeters in size, you can ablate these tumors. If they're multiple, you can resect and ablate. And at this point, when I think they're unresectable, I lean on Dr. Dan Lee to offer some good systemic therapy or just somatostatin. That holds them for 5-10 years. And so that's what we're doing. We're just trying to balance out these things as we go on. And then, can we do concomitant big surgeries at the same time? And this is a question, again, for the consensus conference that we discussed. And so I, again, went back to our registry, the California Cancer Registry, and looked, can I do a Whipple, which is the biggest pancreas operation, or can I do a distal pancreatectomy with splenectomy and do a liver resection at the same time? And so I basically said, yes, yes, we could do this, and no in terms of for type 3 disease. What I also showed was that the survival and the complications with these operations was no different. Now, mind you, these are small numbers, but that's all that's out there. People tend not to do these as combined operations. And but what I'm just trying to prove is safety of being able to do this at the same setting. Again, I will leave it to the discretion of the surgeon. If he does not feel that he's comfortable doing it, then not. We're actually presenting that work at the American Hepatobiliary and Pancreatic Association at the end of this month in March. And then we also looked at small bowel and liver work at the same time, and we established safety on that, and that we're presenting this year at the Clinical Congress in San Francisco for the American College of Surgeons. So again, we're trying to move the pendulum. We're trying to move along what we do for liver work, and we're very, very aggressive when we think it is prudent to be so. And again, here's an example of large mass on the left side, what a neuroendocrine metastasis can look like. There was a single mass right at the back there, which you actually don't see on this cut of the scan, which we enucleated. Point being here, you don't need margins. You just need to go close to the tumor. You don't need to get out healthy liver with it. These are almost like an eggshell, you know, taking out the tumor right off the liver there. But you have to be meticulous because these are supplied by arterial and venous branches going into the liver. This was actually a fairly complex case and was somebody I trained, I want to say about 7 or 8 years ago. He brought his uncle to see me because he was progressing on therapy, had a carcinoid down in the rectum, and then multiple liver metastases. But he was in great shape. He was hiking every day. And said, "Doc, I can't keep going on. I seem to be losing my energy." And so looking at the burden of disease right here within the liver, you can see that, yes, maybe there is a chance if I can somehow get this portion of the liver to grow, I can take all of this out pretty safely, even though I do have a tiny spot on the other side. So my approach was what I talked to you a little bit earlier is come in, block off the flow to the right side. This is the right side, this is the left side. Blocked off the complete flow to the right side. We now suddenly have 1.5 liters going to the left side, got some compensatory hypertrophy on the left side, and then proceeded to basically map out the disease and then go in and resect that. Again, you can see healthy liver, did extremely well after surgery, and is doing well. So he was then, based on the burden of disease, placed on long-acting somatostatin. I don't think I could do any of this without Dan and my team members in the team. I think it's all of us putting our minds to this. So Dan's been critical in the last 3 years in actually changing the opportunities that our patients now have in terms of systemic options and how to approach these. And we'll be honest, we're learning from you at this time, and we're trying to do our best for you at this time based on all the current literature and the current data that we have from experience and publications that we have there. John Kessler is our interventional radiologist who does all the embolizations for us. He's probably the best sharpshooter I know. Phenomenal. He'll get to the site that you want him to and take care of anything that we really want him to do. John Williams is the scientist that I'm working with on developing a molecule. We've gone through 2 generations. We're on the 2nd generation now. The first didn't really work, but he's a structural chemist and is the backbone. Sue is our pathologist, dedicated now to neuroendocrines, and is actually developing a whole separate method for classification. These are our nuclear medicine people, radiation people here. That's actually me without a beard, so probably civilized there. So that's our team, and I think none of this could have been done without all of us integrating together and working in unison. So our tumor boards are actually well attended. We have about 30 to 40 people there at the tumor boards thinking this through and how we need to approach these cancers. So last but not the least, in the conclusion, what I'm going to say here is I do think surgery at this point is the mainstay of therapy if the tumor is resectable. Yes, there are certain tumors that are not resectable. And so on those, I would back off and say, I don't think I can resect this patient population. We do have a lot of opportunities. Somatostatin has changed the way we do things. New immunotherapy trials that are coming up, very encouraging. The initial results of PRRT were very encouraging, but I definitely don't think it's panacea. So you have to take a deep breath again and move along with us. And I think the future is still very bright with a lot of new things coming on the horizon. So in conclusion, I think that as long as you can leave behind 20 to 30% of good liver, go for it, okay? I balance it out. I probably left less 10 years ago. Now I'm more conscious. I take a lot more time to carve out and leave. I ablate, trying to leave more liver behind for this patient population. And I use microwave energy, irreversible electroporation, or the nano knife, all in conjunction with my primary modality, which would be surgery here. And I reserve ablation for tumors that are less than 3 centimeters in size. Thank you very much. I'd be happy to take any questions. Yes, sir. You want to come with the mic because I think there are people on the...
Well, he's coming. You gave statistics for recurrence on the ablation. What about NanoKnife?
So the NanoKnife experience is not huge. You're absolutely right, and that's a great question. Even though I probably have the largest experience on the West Coast, I don't think I have more than 40 patients that I've used NanoKnife on, and a lot of the patients that I've used NanoKnife on are not neuroendocrine only, so it's a hodgepodge of colorectal liver metastases, which is more common than neuroendocrine tumors, and some of the other rarer tumors. And it's usually, if it's a single spot, let's say I've cleared everything else, and there's one spot which is sitting right on the blood vessel. And I mean, I could show you pictures and long-term survivors that are doing phenomenal. The other place where I've used it is, and this is very interesting because we did publish this, just as a case report as trying to extend the logic of what you can do, is when you shave it off or carve it off these blood vessels, you know that there's going to be a microscopic positive margin along these blood vessels. So I put the needles in parallel to these blood vessels afterwards and then pass the electricity across it. Now you would think that the electricity is going to jump over the blood vessel. So we've thought of all that. We take a little bit of the internal fat and we actually put a cover on it and then allow the electricity to actually go with phenomenal results. Where I haven't succeeded is actually using NanoKnife through actual tumor if I'm leaving behind. And I was again trying to see if I could extend the logic of what I was doing. I have not been successful with that because if you're trying to do it on big, long tumors, you're going to recur along those long tumors or the bigger tumors. You have to do them for 2 centimeters or smaller, and if you're going to do it for a little bit longer, then you have to march the needles across along with the NanoKnife. So it's a limited experience for the NanoKnife at this point. Yes, sir.
You made a strong point at the beginning of the talk about the value of removing the primary tumor before going after metastases or at the same time, perhaps. But sometimes I think you have a patient who presents with liver metastases only and initially no indication of where the primary might be.
Yes.
And in some cases, like a high-grade disease, there might be, it might not be expressing somatostatin receptors,
yes.
So that gallium-68 donates might not show anything. So in a case like that, how would you go about trying to locate the primary tumor?
Great question. And again, I will tell you there are patients that are out there that you should meet of mine that are absolutely in the similar predicament where we thought it was a neuroendocrine tumor and it was high grade, but it was solitary. Dan was actually treating them with systemic therapy because when they're high grade, surgery is not. So what was your name, sir? Clark. So, sorry, Larry, okay. So what Larry was saying is, so neuroendocrine tumors are 3 grades. There's well-differentiated, there's moderately differentiated, and there's high grade. The typical surgical disease is well-differentiated and moderately differentiated. These are the ones that are not poorly differentiated. The ones that are poorly differentiated or high grade are a lot more aggressive on their biopsy when you see those patients. However, even within those high-grade tumors itself, so let me back up for a second. High-grade tumors, you shouldn't rush into surgery Because if you think you can go and take these out with surgery, they're going to recur somewhere else. So we offer them systemic therapy upfront. We discuss it. And then if it continues to remain localized, we have gone after them. Actually, if you look, I didn't put that slide up. In our, when we looked across the cancer registry, the California Cancer Registry, we also noted that there were a subset of patients that had high-grade tumors that had been incidentally operated on because they were diagnosed with neuroendocrine without having done a formal workup to see if there was any metastatic disease. And even in that patient population where they took those tumors out, they actually did better. We cannot make that recommendation on a public platform at this point. So I would be very cautious for saying that. But I think you can definitely make exceptions. So we share patients that are high grade, localized only to the liver, single spot, no other primary anywhere else. We have not been able to find it. And we've gone after the primary liver cancer, liver neuroendocrine tumor and resected it. And they're doing well, actually. The most recent actually is almost 2 years out now. He's almost 2 years out. And he was seen across the West Coast. And I told him that, you know, the only reason I said I'm offering this to you is because biologically, you're not behaving like a true high grade. You're not behaving like a person who's throwing out another 100 metastases to different parts of your body. So I said, I'm willing to give you the chance. If you want to consider it, it would not be textbook medicine, though. And so it's all individual. You're absolutely right. So you have to break the barrier sometimes. Yes.
There's some questions that came in through the live stream.
Yeah.
So one was, how well can MRI diagnose NETs if you have hip replacement or other metal implants?
Great question again. So the issue with metal implants is, as you know, it's a magnet, it's a magnetic resonance imaging. Unfortunately, some of the MRI machines now have shields. It also depends on the type of replacement they've had. Some of them, they can put these partial shields over that area and still do a scan. We could not do MRI for patients with pacemakers either, but they've now come up with shields even for certain types of pacemakers where you can now do MRIs in them. But you're right, I would say 90–95% of the patients with metal implants are still not able to get an MRI. So the CT scan would remain the gold standard for that. Anybody else? Questions?
There's a couple other questions that came in through live stream. One is, would you prefer to use the Metastases analog instead of ablate the small metastatic liver lesions?
Yes. At this point, yes. The answer would be yes. I wouldn't rush after ablating a lot of these small incidental lesions. It also depends on the number. Usually if there are like, 20 or 30 or 50 of them, there's no point trying to ablate each one of those. So yes, my first reaction is if you get great stability with something that's non-invasive, absolutely.
And can you talk about repeat surgery? How many times can you cut the liver? And what happens to the rest of the liver that's left after surgery? Does it grow back?
So the liver regenerates usually back to 100% in volume. It takes about 3 months. So you can do repeat surgery any number of times you really want. I have done up to 3 or 4 times on patients over a 10-year span. But the issue is not that. The issue is the location of the metastases. If the tumor recurs on a major blood vessel that is either coming in or going towards the heart, then surgery automatically drops out because the main pedicles are beginning to get involved. And every time you do a major surgery and you take out a major chunk of liver, you're actually sacrificing some of those pedicles as you go along. So it's a little bit of a balance there. You could do surgery as long as the liver allows you anatomically to do so. So I wouldn't put a finite number on it. I've done it up to about 3 or 4 times, or people who have had surgery in Kaiser for 2 or 3 times and then come moved insurance and then come to see me at that point, and I've even operated on them and they're the 4th surgery. So it's doesn't really, a number is not important. Yes, ma'am.
With regards to the pancreas, is it easier to operate on the tail side or on the head side?
So I think both are complex, but usually the head side is more complex than the tail is. And the reason being, as you saw, all those blood vessels are draining along the head of the pancreas straight up to the intestines, straight up to the liver. So from the intestines, the blood flow, that there are a million tiny veins that merge into a couple of big veins that go straight under the head of the pancreas and go straight into the liver. So the head side, which is called the Whipple operation, is far more complex than a tail operation. Okay, a tail of the pancreas, a body of the pancreas. The body of the pancreas has another blood vessel that it can actually encase, which is the main artery going up to the liver and the main artery that's going towards the spleen. And so that has its own level of complexity associated with it. But if you were to ask me which is the more complex of the three, I would say the head is more complex. It's a good 6-hour operation. If it's a straightforward one, it'll be between 4 to 6 hours, somewhere in that range. A tail of the pancreas operation is about 3 to 4 hours. And if it's very complex, you can add an hour or two to that.
One more question. What's the lifestyle implications for a person after liver surgery? For example, can they drink alcohol?
So everything we do should not take away quality of life as I look at it. So I think drinking alcohol or having a drink socially is absolutely acceptable. So it's not to take away your quality of life. But we definitely don't want you to drink and come into surgery the next day. We definitely don't like that. Especially, oh no, I trust me, people coming in for liver surgery think that this is it. And I've had patients go out and gamble all night and drink and then show up in the morning smelling of smoke and liquor, basically, because they think that this is their last day alive. And so I actually sometimes cancel their surgery because I think the playing field changes with a lot of alcohol on board. It makes your liver a little bit more oozy, et cetera, et cetera. So I definitely recommend people refraining from alcohol for about 3 weeks before surgery. There's no data against typically support that, but that's my recommendation.
I guess
usually.
on the flip side of it, is there something that people can do to help promote liver health and preserve liver function and maybe a complement to the treatments that you're doing?
There is no secret. It's just living healthy. Okay, there's no specific thing that you can do that's going to improve liver health as such. Any more? Yes, sir.
So my wife is the patient. We had a very successful surgical reduction, both the midgut, mesentery, and liver reduction. There's some residual liver burden, tumor
Yes.
burden, octreotide, going on 6 years.
Yes.
So at some point, hopefully many years down the road still, we're going to see perhaps one of the targeted tumors we look at monthly start to show maybe a little bit of growth, and we say, we're going to need to do something. Could you talk about, I'm a little confused with regard to embolization, what the logic is that would say it's a candidate for it, and how do you choose bland versus radio versus chemo? And then maybe how successful it is. So the process of choosing which embolization, and is the scenario I described one in which you would look at using embolization, which one you would choose and how successful is the approach?
Okay. So I'll give you my simplistic way of looking at this. I think the first choice should be ablation over embolization for a single lesion that's probably growing and everything else is stable, all right? And only if it's accessible. Accessible as in it can get to the point the needle can get there safely without causing any collateral damage, i.e. you're not going through bowel, you're not going through lung or anything to hit that particular tumor. So that would be my first recommendation. Chemoembolization is short-lived and localized. If you're giving it for a certain tumor, you want to reduce the size and then go after it surgically. It's usually good. It works pretty effective, but again, you need to complement it with something else because it doesn't eliminate the tumor 100%, okay? The intent is there. you could do chemoembolization a second or a third time, and you could try to do that. What's most important in terms of the embolization is when they do the first scout film to see what kind of vascularity the tumor is receiving, you have to realize that the tumor's not got only one blood vessel going to it, it's got a ton of blood vessels going from all sides. So there's going to be a certain amount of escape of whatever therapy you do to that. So that's why I said if I can put a needle into it and burn it first, then there's no escape for that particular one tumor that you're looking at. With chemoembolization or radioembolization, there's always going to be collaterals that are still going to keep that tumor perfused. You're going to get some control, you're going to get some slowdown, and if you're lucky enough, complete resolution, but that's not a given. Did I answer your question? And where does bland come in? Is absolutely. So I think bland is actually equally good. And so you don't really need to use radioisotopes or chemo if you're just trying to control one particular metastasis. Bland works just as good. I would put that question to Dr. Kessler next time he's on the panel, Jonathan. And we have this debate constantly, and we actually run our clinics in a way that Dan comes in the afternoon to my clinic in the after 1 p.m. And Jonathan Kessler is also in the same clinic. So we see patients together in the afternoon portion of my clinic all together, so that if we want to bounce off each other, we can immediately bounce off our therapy. So next time you see Kessler on one of the platforms giving a talk, you should ask this pointed question to him directly too. But that's our general thought process, what I just shared with you. Yeah. Yeah, if I don't need to use chemo, I don't need to use radiation beads, I think that's the best way to go. And if it's just a single person that single tumor that we're focusing on, and it has a good blood vessel going to it, bland is perfectly fine. We good? All right, Dan, come on up. Thank you.